Okay, thanks, Professor Chen. And I'm HUANG Yixiao, and my topic is clustering the ALS survival data, and also we try to predict the survival time of the patients. And it's actually a comparative study, which means that we use some new methods to compare the models with some baseline model, and I'll introduce it later. And so today's content will be 4 parts. And the first part, I'll introduce some background knowledge of this ALS disease and also the data we used. And also I'll introduce the models that we implemented in our analysis. And also I will present some preliminary results and also some future work will be discussed. And the first is about the ALS, and Professor Chen has already introduced a lot about this disease. And it's actually a very rare disease whose clinical trials are typically small with a larger study, including fewer than 1K participants. So this is actually makes it difficult for us to applying large machine learning algorithms or deep learning algorithms to have some inspection on the data, because normally the algorithm requires a large samples over than 3K or 4,000 patients. So this situation changes when the PROACT database is created. After this database is created, and it's actually the largest database containing the clinical trial data of ALS patients at present. And it combines data from the 23 ALS studies with over than 10K patients. So this is actually make our analysis possible. And next I'll introduce, and because this disease is that actually has limited therapeutics option at present, and this is actually resolved. This is actually because we know little about this disease, and so generally speaking, we hope to use it by our study. We hope to know more about this disease, and specifically, we have 3 objectives. And the first is to cluster the patient using clinical features and also the survival information. And this is especially helpful in aiding the clinicians to make decisions in treating the patient with different groups. And this is also called the precision medicine, which is widely used in the treatment of cancers, where the clinician will use different medication or treatment methods for patients with different groups. And the second objective is very intuitive. We want to predict the survival time of the patients and from the beginning of the trial. And lastly, we want to conduct the efficient importance analysis to find the most influential factors related to the disease. And next, I'll introduce the features that we used in our study. And actually, this database contains a large number of features of the patients. But actually, this database combining different studies of patients. So patient in a different study will have different features. So there's a large proportion of missing data in the features, such as, for example, the patient may only have the weight information and the blood pressure, but it doesn't have the urine test information. So we need to leave out the data, leave out the features with a large amount of missing data. Otherwise, we can't do further analysis. So to summarize, this data can be divided into 6 categories. And the first is about the demographics, which is about the age, gender, and height, weights. And also we record the ALS history, such as the time from the onset of the disease. And also the ALSFS is actually the rating instruments for assessing the disability of the patient, such as we assess its gross motor or bulbar and respiratory function. And the last 3 information is about the clinical information of the patients, which are the physiological information and also lab measures, such as urine tests and also the heart disease factors. And lastly, we record the medication history of the patient, such as the baclofen and also the Riluzole, which is the only one treatment that is approved by the FDA to use in the hospitals to treat the patients. And next, I'll introduce several models that we used in the study. And the first is actually the baseline model, and it's called the COX-PH. So its full name is actually the proportional hazard models, and it's created by the scientist Cox. And it's actually based on 2 background knowledge. And the first one is the survival function. It actually describes the probability of survival. So it's defined as the probability that the event, you can say the death is later than some specific data point T. So intuitively, we can then estimate the median survival time of the patient by setting this survival probability to 0.5 to get the median survival time. And alternatively, you can also model this process by using another function, which is called the hazard function. So this actually, intuitively, it actually describes how dangerous the patient are. So it's defined as the probability of the instantaneous rate of the occurrence of the event, and is defined as this below. And using some algebra, we can find that it's actually related to the survival function by this formula. So because if we define this survival function, then it will be hard for us to model this process. But we can try to define this hazard function by using some probability distribution, such as for example, we can assume constant hazards with respect to time by setting it to lambda 0. So this is actually what the proportional hazard models do. So it's actually define this hazard function as this below, and this x is actually refers to the covariance of the patient. So you can understand as it has the clinical information of the patients, and the beta is actually the weighting parameter over the clinical information. And you can also define different hazard function by, for example, you can setting the hazard function as the Weibull distribution, then you'll get the Weibull models. And there are two new methods that we used in our study. And the motivation is that we find that most of the study specifically in ALS patient, they only use the survival time or part of the clinical information, such as the ALS-FIS, which I mentioned before, the scaling instruments to try to cluster the patient. For example, we have some of the study tried to use the K-means algorithm to use the survival time to cluster the patients and define it as a high risk and low risk patients. But we find that this information may be uncorrelated with the hidden cluster. So we try to use all of the information, the clinical information, and also the death information to try to cluster this patient. And this algorithm made it possible. And for the first algorithm, which is called the variational deep survival clustering, and the reason why it has a variational is that it uses a variational autoencoder in the models. And this actually it used the clinical data and also death information of the patient. And the delta refers to the sensory indicator of the patient. For sensory, I mean that some of the patient may leave out the study with no reason, or so we just know that the death is happens within some periods, but we don't know the specific time. And specifically, we used so in our study we only be curious about the right sensory, which means that the death date is later than some specific points. And to save time, I won't introduce too much about the algorithm, but to summarize, it's actually a twofold problem. So we first use the Bayesian rule to infer the hidden cluster assignments, and also secondly, we try to conduct the survival analysis for each cluster using the latent representation of the covariance, which is done by using the encoder in the model, and also we use the cluster and also the sensor indicator to model the survival time. And the second model is actually the motivation behind this model is actually similar to the first model, but the difference is that it actually only it didn't use the clinical information in the clustering. So it defines the loss as the Dirichlet process of the loss, and also the second loss and the third loss is actually evaluation metrics. The first is actually it tries to define the survival time loss use the LT, and the calibration refers to how much the model estimate risk. And I'll introduce this later. And
so please keep track on the time a little bit.
Oh, sorry. Okay, I'll make it faster. So actually, there are three metrics that we use in our study. And the first is a concordance index, which means that we try to rank this we try to rank this patient in their risk, and this risk is naturally defined by their survival time of the patients. And also the secondly, we use the relative absolute error, which is the survival time of the patients, and we calculate this for center patient, also the non-center patient. And the reason why we need to treat it differently because is that for center data, we only know that the death date is after some specific data points. So once the prediction is after the specific data point, then we'll treat this error as 0. And for the last one, the calibration slope is actually trying to evaluate how much the model estimate the risk. So an ideal calibration slope is 1. And this is the current result of our models. So actually, we can draw some observation from the observation from the results. And the first is that the Vertex yields similar performance to the baseline Cox pH, and secondly, the SCA gives the best concordance index over the stream models. But we can see that the calibration slope of the SCA is actually very large. So it tends to overestimate the risk. And for the future work, there are 3 future work I plan to do. And the first is because our first objective is to cluster the patient, but for the ALS patient, we don't have the ground truth cluster results. So we need to have more analysis of the interpretation of the cluster results. And secondly, we also want to analyze the strong predictors of the clinical features in these models. And lastly, because this data have a large proportion of missing data, so we need to plan to try some new imputation methods to make the imputation more reasonable, so that we can have so that we can boost the performance of the model. And also, we want to use the dimensionality reduction so that we can reduce the number of features used in our models. And thanks. This is our presentation.